Needle EMG waveforms. This demonstration of needle EMG waveforms is designed to show a typical example of each potential so that one is able to recognize a given EMG wave without any difficulty. The sound of EMG waves is paramount in recognizing the typical EMG waves. Often the characteristic sound of EMG waves permits recognition of these waves without looking at the waveform. These waveforms have been selected from among many obtained in the UAB EMG Laboratory over a 30-year period on the basis of their typical characteristic shapes and sounds. We have used the standard needle EMG setups, filter setting from 20 Hz to 10 kHz, and sweep velocity of 10 milliseconds. Sensitivity varies depending on the waveform, ranging from 0.1 millivolts to 2 millivolts. Downward deflection is positive. With monopolar needle recording, this assumes that an active EMG needle electrode is placed on the cathode. For further information about the characteristics of EMG waves and sounds, please consult Chapter 5, Needle EMG. Insertion activity. Insertion activity and spontaneous potentials are studied at rest. Insertion activity is the electrical response of muscle membrane to the insertion of the EMG needle. In normal individuals, insertion activity disappears as soon as the needle movement stops. When the insertion activity persists beyond the cessation of needle movement, it is described as increased. Thus, insertion activity is usually increased when abnormal spontaneous activity is present. An increase in insertion activity is usually the first EMG clue to suggest the presence of abnormal spontaneous potentials in the muscle. When insertion activity is not elicited on needle movement, as if the EMG needle is going through fatty or connective tissue rather than muscle, it is described as decreased. Increased insertion activity alone without fibrillations, positive sharp waves, or myotonic potentials is not clinically important. On the other hand, decreased insertion activity is clinically significant because it is indicative of fibrosis or fatty replacement of muscle. One has to remember that rare fibrillations or positive sharp waves may be observed even in an area of decreased insertion activity. Thus, one is not exclusive of the other. Watch and listen to normal insertion activity. Normal spontaneous potentials, end-plate noise, and end-plate spikes, nerve potentials. Spontaneous potentials are defined as any activity which persists beyond the cessation of needle insertion long enough to be recorded without undue difficulty. There are two normal spontaneous potentials, end-plate noise and end-plate spikes, or nerve potentials, occurring at the end plate. Often the patient feels tingling or pain when these normal spontaneous potentials are observed, especially with end-plate spikes. Their sounds and shapes are characteristic enough to be easily and clearly recognizable. The most important criterion for recognition of these normal spontaneous potentials is the initial negative deflection. Almost all pathological spontaneous potentials have an initial positive deflection. End-plate noise is generated by the irregular, continuous, low-voltage, short-duration waves with seashell sounds, representing spontaneous miniature end-plate potentials. End-plate spikes, nerve potential, are irregularly firing brief spikes with a sound like the sputtering of fat in a frying pan, originating from the nerve endings. Watch and listen to the end-plate potentials and end-plate spikes, or nerve potentials. Abnormal spontaneous potentials. There are 7 abnormal spontaneous potentials. Positive sharp waves and fibrillation potentials. Fibrillations and positive sharp waves are the cardinal signs of denervation process, representing axonal degeneration. The degree of fibrillations and positive sharp waves is a rough estimate of the number of denervated muscle fibers. However, they are not pathognomonic of denervation because they are also observed in active myopathy and myotonia. It is more likely that fibrillations and positive sharp waves in active myopathy and myotonia represent hyperexcitable membrane. Thus, fibrillations and positive sharp waves should not be called denervation potentials. Positive sharp waves. Positive sharp waves are characterized by a sharp initial positive deflection followed by a relatively prolonged negative slope and typical dull thud sound. Positive sharp waves, like fibrillations, are considered to originate from a single fibrillating muscle fiber. The only difference from fibrillations is that they are recorded from an injured area of the fiber and represent injury potentials. Certainly, this is obvious in practice in that positive sharp waves are much more easily evoked by EMG needle movement than are fibrillations. In essence, the electrophysiological characteristics and clinical significance of positive sharp waves are identical to those of fibrillations. Watch and listen to positive sharp waves. Fibrillation potentials. Fibrillation potentials are biphasic or triphasic, short duration, less than 2 millisecond, low amplitude, less than 100 microvolts potentials with an initial positive sharp deflection. Fibrillations, which are usually detectable by a needle EMG study in the muscle 2 weeks after denervation, represent the action potentials of single muscle fibers that are spontaneously twitching in the absence of innervation as an expression of denervation hypersensitivity. The most important criteria for recognition of fibrillations are the initial positive deflection and regular firing. There's also a characteristic sound, like raindrops on a tin roof. A potential with an initial negative deflection is not fibrillation. Another important point to remember is that though each single fibrillation fires at a regular rate, many fibrillations firing at the same time sound like irregular firing because their firing rates are different. Watch and listen to fibrillations. Myotonic potentials. Myotonic potentials are the most specific potentials in the needle EMG. Myotonic potentials are spontaneous potentials with waxing and waning amplitudes and frequencies, producing the classic dive bomber sound. They are easily induced by needle insertion and movement, muscle tapping, or minimal voluntary contraction of the muscle. Myotonic potentials are characterized by an initial positive deflection, either in the form of positive sharp waves or fibrillations, depending on the relationship of the needle to the muscle fibers. If a single myotonic potential fires at a slower rate, this may sound and look like fibrillations or positive sharp waves. Myotonic potentials are generated by the spontaneous, constant depolarization of the muscle membrane. It is important to differentiate myotonic potentials from complex repetitive discharges, or CRDs, by waxing and waning of amplitude and frequency of myotonic potentials. If myotonic potentials are recognized by the needle EMG test, the patient is considered to have myotonic syndrome until proven otherwise. Only a few other diseases show myotonic potentials on the needle EMG. One of them is acid maltase deficiency. Watch and listen to myotonic potentials. Complex repetitive discharge, or bizarre high-frequency waves. Complex repetitive discharge, or CRD, refers to the repetitive discharge of complex potentials with sudden onset and cessation and the characteristic sound of a motorboat or motorcycle. The waveform of a single CRD is typically polyphasic, complex, and uniform from one discharge to another. During discharge, there may be abrupt changes in their shape, amplitude, and frequency. The most important criterion of CRD is a lack of waxing or waning of amplitude or frequency of potentials. Thus, there is a distinct difference between CRDs and myotonic potentials. In CRDs, there is no waxing and waning of amplitude or frequency of the potentials, whereas waxing and waning of potentials is a sine qua non in myotonia. This distinction is important because myotonic potentials have a more specific connotation. CRD is usually an expression of hyperexcitable muscle membrane. CRD, though impressive in the needle EMG, is not associated with any clinical counterpart. On rare occasions, CRDs may be observed in isolation in normal paraspinal, iliopsoas, and sphincter muscles. In pathological states, CRDs are usually associated with profuse fibrillations and PSWs, regardless of diseases. On many occasions, the generator can be accurately pinpointed because with a minimal needle movement from the generator, CRDs will cease firing. Watch and listen to CRDs. Fasciculation potentials and spontaneous MUP discharge. Clinically, fasciculation refers to the visible twitching of muscles. It's usually fleeting, but can be continuous, simulating a bag of worms. Fasciculation potentials. Fasciculation is recorded as fasciculation potentials by the EMG needle. These are characterized by the irregular firing of single MUPs and are usually accompanied by visible needle movement. Fasciculation potentials may mimic normal or abnormal MUPs. Depending on the closeness of the needle to the origin of the fasciculation, the sound can be crisp, representing nearby fasciculation potentials, or dull, indicating distant fasciculation potentials. In the former case, fasciculation potentials are invariably accompanied by tiny visible needle movements, an important distinguishing feature from other spontaneous potentials. Fasciculation potentials are spontaneous discharges of a group of muscle fibers representing a whole or possibly part of a motor unit, and are thought to originate from the eupaptic firing of MUPs from a lesion in the anterior horn cells or entire axis of the peripheral nerves. Fasciculation potentials are observed in normal muscle as well as in anterior horn cell diseases, cervical spondylotic myelopathy, radiculopathy, and demyelinating neuropathy. Watch and listen to fasciculation potentials. Spontaneous MUP discharge. Sometimes a single fasciculation can be continuous, firing at an almost regular rate and mimicking a regular single MUP. In this instant, it is important to ascertain that the muscle is completely relaxed and to recognize the tiny visible movement of the needle. Careful, prolonged analysis of the recording shows that the firing rate is not always regular. It is likely that this continuous fasciculation is what Buchthal et al. Call spontaneous MUPs, which have been described in infantile spinal muscular atrophy. Watch and listen to spontaneous MUP discharges. Myochemic potentials. Myochemic potentials refer to specific spontaneous potentials in the needle EMG, which are characterized by the rhythmical firing of grouped MUPs. The most important distinction from fasciculations is that instead of a single MUP, fixed groups of MUPs are firing in bursts, usually at a regular rate in myochemic potentials. Myochemic potentials occur in bursts of groups of 2 to 10 potentials and are characterized by typical sounds like the footsteps of marching soldiers. They are not affected by voluntary movement, sleep, or needle movement. Certainly they can be induced by percussion on the muscle. Unlike myotonic potentials, myochemic potentials do not wax or wane. Some have maintained that myochemic potentials may be regarded as grouped fasciculations. These should be differentiated because of their distinct patterns and sounds and different clinical implications. Like fasciculation, myochemic potentials are generated from emphatic firing of MUPs from a lesion along the peripheral nerve axis. Myochemic potentials are typically seen, but are not a sine qua non in clinical myochemia. The reason for this is that in clinical myochemia, other EMG potentials can be observed: continuous fasciculation and continuous muscle fiber activity, or neuromyotonia. Myochemic potentials are essential findings in myochemia cramp syndrome. Myochemia is most frequently seen in Isaac's syndrome, demyelinating neuropathy, radiation plexopathy, and timber rattlesnake envenomation. Watch and listen to myochemic potentials. Neuromyotonic discharges. Neuromyotonic or neurotonic discharges refer to the continuous muscle fiber activity or motor unit potentials firing at 100 to 300 Hz. These potentials may change in amplitude and duration during continuous muscle fiber activity. This high-frequency, amplitude-changing discharge produces a unique musical sound like the buzzing of swarming bees that differs from those of other spontaneous discharges, including myotonic discharges. Neuromyotonic discharges are unaffected by voluntary activity. Classically, neuromyotonic discharges persist during sleep and under general or spinal anesthesia. During voluntary contraction, many motor units fire successively with overlap. Studies suggest that neuromyotonic discharges are generated from the hyperexcitable peripheral nerve anywhere from the proximal segment to the axon terminal. The clinical counterpart of neuromyotonic discharges is continuous muscle contraction, which may be painful in severe forms and give rise to an abnormal posture, difficulty relaxing the muscles, or clinical myochemia in milder forms. Neuromyotonic potentials are a sine qua non for a diagnosis of Isaac's syndrome and familial continuous muscle fiber activity syndrome. Neuromyotonic potentials are also reported with spinal muscular atrophy, peripheral neuropathy, and tetany. Watch and listen to neuromyotonic potentials.